Hello, and welcome to this online event. I'm Danielle Jeffries, an analyst at the King's Fund, and I'm going to be chairing the event today, which is looking at reducing health inequalities for women in deprived groups. I'd like to start the session by thanking our event sponsor. This event is being sponsored and funded by MSD. We have a great panel of speakers today representing a whole range of perspectives, and I'll invite our speakers to introduce themselves shortly. But information on who they are can also be found in the speaker biographies, which are just below the video. We have a really great audience for this event. We checked just before coming live, and just over 1,700 people have signed up so far. And we have a real range of people watching today from across different sectors, including charities, NHS commissioners, providers, private organisations, patient representatives, and universities. Just to give you a quick overview of today's session, this event is live and we'll start with a panel discussion. We'll then do a live Q&A, so please submit your questions in the Slido box, which is to the right of the video, which is also where you can upvote other questions, and we'll aim to answer as many of the most popular questions as possible. We will also be putting some poll questions to the audience. These will flash up at various points during the session to the right side of the video, so please do take part in them. We also encourage you to follow the conversation on Twitter using the hashtag KFOnline. And we also recommend you look at the resource page, which you can navigate to using the menus on the left-hand side. I'd now like to invite our speakers to briefly introduce themselves. So, Louise, can I start with you? Louise.
Apologies. Hi, everyone. My name's Louise Clark. I'm Director of Strategy and Transformation for Bradford District and Craven Health and Care Partnership. But I'm also a GP at Bevan in Bradford, which is an inclusion healthcare practice.
Thanks. And Rebecca?
Morning, everyone. My name is Rebecca Mbewe. I am co-director for an organisation called 4MNet CIC. 4M stands for My Health, My Choice, My Child and My Life. And we provide mentoring and support for women living with HIV going through the perinatal journey.
Great. And Rayhan?
Thanks, Danielle. Afternoon. I'm Rayhan Khan, and I'm an obstetrician and gynecologist in the East End of London. And I'm the Regional Clinical Director for Gynecology for the whole London region.
Thanks, Rayhan. And Fazana?
Hello, everybody. Thanks for having me. I'm Fazana. I'm a GP in Newham in East London, close to Rayhan, and I've been a GP for 21 years. And Newham, as we know, sadly had the highest COVID death rate in the first wave. And I run a practice of 5,000 patients. Really looking forward to the conversation.
Thanks, Fazana. And Priya?
Hi, I'm Priya Agrawal. I'm Global Lead for HPV vaccines, calling in from the US, but used to be an obstetrician and gynecologist in London, working with Rayhan.
Great, thanks all for joining us today. So just before we begin the panel discussion, I just wanted to note two things. First thing to note is that we'll often be discussing women as a broad group in this event, but women, as I'm sure you'll all recognise, is not a single homogenous category. It refers to a wide range of people who have different health concerns, different outcomes, as well as many different characteristics, including disability, ethnicity, race, sexuality, gender, socio-economic status, and many, many others. All of these factors intersect to result in differential impacts on health. The second thing to note is the context that we're having this discussion in today. Today, we won't be discussing some topics. So, for example, the overturning of Roe versus Wade. But we do want to acknowledge that these events shape how we think about women's health. And we also wanted to take a moment to remember Dame Deborah James, who very sadly passed away yesterday, and the incredible legacy she leaves behind. As you all know, Deborah campaigned tirelessly to raise awareness of the importance of screening and early diagnosis of cancer, particularly bowel cancer, and to change the conversation about what it means to be living with the disease. We are all incredibly inspired by her work. So now on to our panel discussion. So we know the difference in female life expectancy between the most deprived and the least deprived areas of the UK is almost 8 years. But what do you, our panel, think are some of the biggest barriers facing women's health outcomes at the moment? So Rayhan, can I come to you first?
Thank you. I think there's potentially a constellation of biases which have impacted women over generation upon generation. And you could argue that the pandemic really started to highlight how things like socio-economic deprivation or race can have a really impactful, can be such an impactful event depending on what colour you are, how rich you are, and where you live. Now, I'm an obstetrician and gynecologist. There are some things which are in my day-to-day job very clearly highlighted. So I think a lot of people in this meeting today will know about the 5 Times campaign and will know how little I celebrate the fact that the risk of a Black woman dying as a result of pregnancy has gone from 5 times to 4 times, because it's just not good enough. But actually, there's a lot further in terms of the data to suggest there's more than that going on. And it's not just about mums dying in this country and elsewhere. There's increased perinatal mortality and morbidity. And it's not just within the women's health spectrum about that, it's about gynecology as well, because we see very real differences in terms of disparity for, say, endometriosis diagnosis or cervical cancer outcomes, depending on whether women are from socioeconomic deprived background or Black, Asian or minority ethnic. So that's what I do day to day. What I continue to feel guilty about is the lost opportunities to think about women's lives as a whole. Pregnancy is a window into your future. You get hypertension in pregnancy, you're going to get hypertension in 20 years. You get diabetes in pregnancy, you're going to get diabetes in 20 years. And we can talk later about what we might want to do about that. But even within core women's health, there are potential ways forward to try and help people achieve better health outcomes, I think, overall, particularly by thinking more holistically than just core healthcare and thinking about things like education and society in general.
Thanks, Rayhan. And Fazana, do you have a perspective on this from your work as a GP?
Sure. So yeah, thank you. So Rehan feels guilty. I feel very angry. I've been working in Newham for 25 years. I trained on the GP VTS scheme. I live in Newham. I'm speaking to you minutes away from the Olympic Village. I live in a lovely apartment in Stratford. But actually where I work, which is just a mile's walk from here in Plaistow, we haven't seen that a little bit of luxury. We're celebrating 10 years since the Olympics coming up now, and we have a pocket of luxury in Stratford and the Olympic Village, but actually the rest of Newham is still a very deprived borough. We're 73% BAME, and we're one of the most financially deprived boroughs in London. And as Rehan said, this was something that I think was about before, but COVID really brought it to light. We had the highest COVID death rate. If we think about what happened with women during COVID and a lot of home working, we know that women, there's two things. There's the access to healthcare, but there's also the wider social determinants. So we know women have more caring responsibilities. We know that women found it much harder to devote time when they were home working. So one of the challenges for me is how we make our healthcare system more accessible for women. As Rehan says, they're biased. And, you know, as all biases, unless we actually think about it and we think about changing how we provide healthcare. So a very simple story is I had a 44-year-old lady who registered with me last year after being with a single-handed male GP for many years. She had heavy periods and I gave her some tranexamic acid to help her heavy periods. She called again the week after and I was like, oh my gosh, why is she calling again? I've got enough to do. And she called and she said, actually, Doctor, I just wanted to thank you because I've had periods since I was 11 and I can't go out on my heavy days. And what you've done has changed my life. And that's a really small example. We're not talking about cancers, but actually that was her life that changed, that in 30 plus years of having her period, nobody had managed to help her with language problems, a little bit of embarrassment talking to a male doctor. And then there's the bigger issues, isn't there, Dania? Like, why are MIs, heart attacks, diagnosed so much less? You know, yes, women present differently, but are we writing the textbooks correctly, or are we writing the textbooks for one presentation? So I think lots of work to do, but I think it's great that we've now got a women's health strategy, we've got a levelling up strategy. So I think now is the time to really be acting on our experiences that we've had.
Thanks, Rosanna, and thanks for sharing that example. I think it's a really powerful example of how important this work is and how much impact having these discussions can have on the quality of life of women. So Rebecca, can I come to you? Can I come to you for some of your insights on what some of the barriers the women you're working with are facing at the moment as well?
Thank you. I'm inclined to agree with Rayan and Fazana. You know, there are lots of biases, but if we unpack that, the women that we deal with within the HIV sector, a lot of the things are more social issues. So if you think about the stigma that's surrounding HIV, that makes it really difficult for women to want to come and access care. We're doing a really good job when women are being diagnosed in pregnancy. So we're capturing a lot of women there, but still there's a whole load of women that will not come forward, particularly around stigma. There are other things, migration, language barriers. Some people, because of language barriers, are unable to work out how the system works and how to navigate the healthcare system, or even when they're presented in front of someone, they find it difficult to express or explain exactly what issues they're facing. So that's a whole lot of things. Women come also with domestic violence issues, particularly with an HIV diagnosis. That just compounds the whole thing. And within COVID, again, I'm going to say what Fazana and Rayan said, that really, came to light during the COVID period. So yeah, there's loads and loads of stuff that we need to start unpacking to make sure that we understand how we can deal with some of these issues. Thanks.
Thanks, Rebecca. Yeah, really great insight from you on just how wide these issues spread. And it's a really good point to bring about how this isn't just about health, this is about the wider community and the wider society and the impact these things have on women and their health and their quality of life. Louise, can I come to you from your perspective as well?
Yeah, thank you. I think my colleagues have all pulled out some of the really strong biases that exist. And in Bradford District and Craven, we've got huge diversity. We celebrate the most amazing diversity of our population, but with that comes this huge inequity, and it's magnified in women. We really do see that. And I know we talked about the national picture and the difference in life expectancy. In our district, in Bradford District and Craven, we plotted this out across a bus route. So we took our 622 bus route, which goes from sort of rural Craven up towards North Yorkshire and comes all the way through our sort of suburbs into the inner city of Bradford, where we've got kind of post-industrial real areas of deprivation. And what we saw for women, this is a 10-mile distance, but for women, the difference in life expectancy was 10 years in that 10 miles. But the difference in healthy life expectancy, which is really important, it's how we live those years, was 24 years. That's 10 miles and 24 years. And all of that, that poor health that people live in isn't necessarily at the end of life, that's throughout life. We see women, young women, 20s and 30s, living in incredibly poor health, much of which could be prevented if we worked differently. And that's been a real call to action for us in Bradford. It's something we've been trying to tackle and really pushing our resource around this. And I think one of the things that we've done, we've looked to the Women's Health Network. We've founded this network using existing people with links into communities, whether from VCS organisations, to really ask questions and to try and understand from the perspective of women, what are those barriers? And I think it's been a huge wake-up call to us. Not to jump in with solutions, not to think we understand problems, but actually to stop and think and to listen and to hear, and then think about how we work with those women to do things differently. And we've had some projects under the Reducing Inequalities in Communities that have really started to work across that whole life course, because we know that it's not at particular points, as Rayhan said. Actually, it's across the whole life course for women. So there's certain projects that we've put in that we've tried to co-produce, tests of concepts really, where we can scale up to do things differently. And we've done things around doulas, so working with women during pregnancy, during childbirth, and then in those early months after giving birth, to really understand how to help them to advocate for themselves and to change services to respond to them. We've done work around mental health, particularly in very early infant mental health, looking at bonding, which has had huge impacts, but not only for the child, but the whole family, which is incredible. And particularly at the surgery that I work at Bevan, we got some lottery funding to do a Starting Well project, and that was focused on preconception. So we talk a lot about upstreaming, about prevention, but actually thinking about that window of preconception, actually that's prevention, amplified. That is really such an amazing opportunity. And when we worked with women, we had these ideas about, well, what could we do in those periods? And actually we had to be careful, because you can jump to almost a medical model straight away. But what women told us was help us around protecting our own mental well-being. And that has been so crucial. And the other things will take care of themselves. And when we started to look at this, and this is with some of the people who struggle the most in terms of access to and outcomes from healthcare services. So this is particularly around asylum seekers, sex workers, drug users, people at risk of homelessness. And there are some stories that have come out. So we've worked with some of the sex workers and the people who work with them, who have told us that in the 20 years that some of these people have been working in that service, there isn't a single woman, even with repeat pregnancies, that's been able to keep their child in their care. They might have had repeat pregnancies. And for me, that tells us that we're failing. We're missing opportunities to really work with people and help them to be able to access the opportunities to thrive and to live the life they want to lead. So there's some real crucial insights that people are telling us, that if we listen and work with the women in our communities, we've got an opportunity to change.
Thanks, Louise. Some really stark numbers there about the life expectancy and quality of life. So thanks for sharing for that. And thank you for bringing us on to the discussion about opportunities and what we can do. I think you shared some really great examples of the work you're doing at the moment. So I'd like to open that question up wider to the rest of our panel. So what do we think are some of the biggest opportunities for tackling women's health inequalities in the UK at the moment? Priya, can I come to you?
Yeah, so I heard emotions like anger and guilt, and I think I'm actually feeling really hopeful. Impatient optimism, but hopeful. And I think one of the very live opportunities we have right now to address women's health inequalities is the women's health strategy. So, we've used this term a couple of times, this window of opportunity that this provides in terms of advancing policies for tangible change and progress. I was actually really delighted to see the appointment of a new UK Women's Health Ambassador with Professor Dame Leslie Regan going into that role, who will no doubt be looking to drive the strategy forward. In that strategy, there is something around improving awareness of and treatment for gynae conditions. So some facts before I go to the specific opportunity. So each year in the UK, over 22,000 women are diagnosed with the gynecological cancer. So what does that really mean? It's lots of numbers, right? So 60 people, women, will receive, and their families, this life-changing news today. 21 of these women will die from their cancer today. And actually, awareness of some of these cancers is low and can be confused, like you heard from Fazana, with other gynae conditions. And so one gynae cancer where I think we're really on the precipice of real change is cervical cancer. Now, cervical cancer and inequalities is directly correlated. Right? Deprivation is associated with a higher number of cervical cancer cases. If you look at Cancer Research UK, I think they estimate that cervical cancer affects the lowest socio-economic group, and 65% of cervical cancers are in amongst the poorest in our society. Now, we have prevention in vaccines. We have secondary prevention in terms of screening. Initiation of HPV vaccination is much less likely among girls and young women living in poorest households. So there's a triple inequity, and I will get to the opportunity because I said I'm an optimist, but there is a triple inequity when it comes to cervical cancer. Lower socioeconomic, ethnic minority communities less likely to take up an offer for cervical screening, less likely to get vaccinated, and more likely to suffer from late diagnosis and negative outcomes. But we can eliminate this cancer. I'm just going to repeat that. We can eliminate cervical cancer. We eliminated smallpox. The world's trying to eliminate polio. This is a cancer we can eliminate. WHO put a call out in 2019. It requires vaccination, screening, and treatment. UK can be the world leader in HPV elimination, starting with cervical cancer as a first step. So NHS England, UKHSA, DHSC, lots of UK acronyms, they recognize that we have a potential, but we need to be bold, because if not us, then who? So it starts with political will. This strategy could enable UK government to commit to saying we are going to eliminate cervical cancer, right? Because that requires getting everyone vaccinated. Right, and I always focus on vaccination. Fazana and I have this conversation. It's harder for ethnic minority women. I'm going to use myself. I'd rather give my arm for a jab than open up my legs for screening. Right, let's just be honest. And so I recognize there's many competing health priorities. And as you said, Louise, even beyond health, the pandemic has put us behind. Let's be bold. Let's say the UK is going to be the first to eliminate cervical cancer because it is possible within our lifetimes. And let's use the women's health strategy as one of the greatest opportunities we have right now to get that advanced. So that's why I'm feeling hopeful.
Thanks, Priya, and I totally agree. There's so many amazing opportunities right now. Yes, always great to be hopeful. Did anyone else want to comment on this? Fazana?
So absolutely, inspired by listening to Priya, because this is really big. This is a cancer that we can eliminate. I just want to say that again, because there's not many cancers we can say that about. And I think without getting political, as Priya said, there's lots of tricks that we're missing that we could do something about. So we now have, self-testing for the secondary prevention that Priya was talking about. As Priya says, I don't know a woman that enjoys going for her cervical cytology test. And sometimes because we have, as GP practices, we have targets to hit. That's good, but hitting an 80% target. So what inevitably sometimes happens is the people that don't come for lots of complex reasons, become the naughty patients. If you don't come next time, we might stop your medication. This is not a way to deal with our communities. It can't be you've been a naughty girl, you've been a naughty boy, for other things. So I think there's a real opportunity here to use the enablers such as the self-testing. So Newham happened to be one of the areas in London that was chosen, but sadly not every practice was chosen. So when I applied for this, because I knew it would make a huge difference for my my multi-ethnic population, I was refused it. So we can do something about bringing this into national policy. As Priya says, we can think about how we prioritize HPV vaccine, and gosh, don't we know we can prioritize vaccination when we want to. Look at the world success we've had with COVID vaccination. UK has been an absolute world forefront runner. So actually, if we want to do it, we can do it. And these are young people who we can say, and a great chance to educate them. Yes, there are lots of barriers, and I think it requires and I will say GPs here, GPs like me who know our communities. Yes, there are lots of barriers. There may be parents who will say, actually, I don't need this vaccine for my daughter because she's not going to be sexually active. So it's just about having those conversations about having a vaccine does not mean that it doesn't mandate sex, but actually having a vaccine is just about looking after your health. It doesn't mean that means that you're giving permission for your daughter to go and have sex. So those sensitive conversations with people who understand their communities, the GP and our teams, our practice nurses, I think we're ideally placed for that. So I think it's a great time. We have this opportunity to eliminate a cancer. And I think with all the other competing priorities, we just need to keep that message going, because as Priya says, smallpox was eradicated. We could be at the forefront of something really important here. Jade Goody, many of us are old enough to remember Jade Goody. That really helped bring some younger people in, but we shouldn't be relying on deaths to raise awareness. We can do that all the time. Thank you. Sorry, Rebecca, I know you had your hand up.
No, that's absolutely fine. I was just going to shift the conversation a little bit in terms of when we think about opportunities. I think with the interest or the onset of establishing ICSs, integrated care systems, that would be a really good way of engaging the community, because I think the focus is very much of putting patients at the center and listening to them and what their needs are, and shaping any outcomes via, women themselves. So that would be a really great opportunity to try and learn and implement new strategies and policies and everything else that we need to do that. Thanks.
Thanks, Rebecca. And Louise, it would be interesting to get your perspective on this too.
Yeah, absolutely. Building on what Rebecca said, I honestly believe that we have a huge opportunity right now. We've got the formation of ICSs that will become statutory bodies this week, which is brilliant. This is about being bold together. Taking difficult decisions together is honestly where we need to go with this. We've got all the NHS providers and commissioners in them. We've got local authority, BCSE, public health, just to name a few, but we've got communities as active participants and partners here. So brilliant opportunity. We've got the Fuller report that's just come out, which really sets the tone for how we work together in communities with communities. So another big driver. And we've got a real spotlight on inequalities at the moment across the board, but COVID shone that spotlight. And so to use that as our shared purpose gives us a real lever. So it's shared purpose for collaboration, all doing our bit behind this. But those are tools and levers, and we have to be able to use them and make steps forward. And for me, there's a couple of things. It is really about understanding people in their communities, speaking to, listening to, working with women, particularly those who have the hardest times in trying to access the services the way that we've traditionally set them up. So for me, there is something that every single one of us on this call could do, and it is to go out and listen and hear real stories. I feel really lucky that I work in strategy and I sit in an inclusion healthcare practice one day a week. I connect with people, and until anything we do at a strategic level makes a difference to the person sat in front of you, that is how we know real change is happening. And I think if we all connect in with real people, no matter what our jobs, connect in, listen, and do things that make a difference, that is something we can all do that's tangible. I think it's really important that we back resource behind this. It is not good enough to say that we will all just do this as part of the day job. It takes time, it takes effort, it takes energy, and it does take financial resource. And we have to be brave, we have to be bold, and we can't pull any of that resource for short-term pressures. And that's hard to do, but we must do it. This is about long-term, multi-generational impact. So that is really important. I think the other thing to do is it can seem huge and overwhelming, but if we break it down to doing the right things on the right footprints, and we've coined a phrase in our local place-based strategy about inverting the power to act, and it starts with the person. So if you can do something to make a difference on a person-to-person level, do it. Crack on, do that. If it can't be done there, then go to the community level, start to work on that level. If it can't be done there, then go to place, ICS, national, but start with people and move that power closer to people. And that is really, really important. And I think that gives us all that responsibility, that permission, if we're looking for it, to actually just start to do it in the interactions that we do have. So I am absolutely behind the fact that this is an amazing opportunity. We've got to be courageous, but the time is absolutely now.
Thanks, Louise, and some great examples there of some of the tangible things we can be doing right now to meet those ambitions. So I'd like to open that question out more broadly to the rest of the panel as well. How do we, as a group and as a system, overcome some of these barriers women are facing and make our ambitions for the women's health reality? So I'd open it up. Priya, would you like to comment on this?
Yeah, I'm just reflecting on what people have said. There's one concept, first of all, Louise, you said stories. And I think we know you need stories and data, right? The two are powerful together. And so, I think as we think about listening, capturing those stories, each life matters. I think the other thing we need to remember is we measure what matters, and then what we measure ends up mattering. And we've learned from COVID, so I'm just using vaccination as an example. If cervical cancer elimination becomes the goal, we learned from COVID how to measure uptake of vaccination and the importance of reaching everyone everywhere. So if we don't actually capture data on the inequalities, we don't have a way to capture real-time vaccination uptake, how are we going to know we're making progress? So there's one theme around in my head that's sort of percolating, which is sort of, we need stories, we need to listen, we need the stories, and we need the data. And the second thing that you said, Louise, and it sort of triggered something, is this short-term, long-term. Right. And again, prevention is better than cure. And, sorry, Rehan, I started as an obstetrician and gynecologist. I've ended up working in prevention because of the story that impacted me, right? I lost a 31-year-old woman who had 2 kids to cervical cancer. And she held the consultant's hand in my hand. She said, I've heard about this vaccine in trial. I really hope that my kids will get it. And she had a boy and girl, because HPV is spread by boys and girls, right? It takes 2 to tango. Both need to be vaccinated. We can't put the burden of women's health on women only, right? So I think, for me, it's data as well as stories. It's prevention as well as treatment. And then the third, I would say, is focus. Sometimes I worry when we talk about women's health, and I spent most of my career doing global women's health, we get so lost in all the issues. And I would love us to focus and go for something and show the impact, and then go broader and take the next challenge and show the impact. So data, stories, prevention as well as cure, and then let's focus, be bold, and go for something.
Definitely well said, Priya. Anyone want to come in on that topic, or reflections from Priya? Rebecca?
Thanks for that, Priya. I was just going to add that, and I agree with everything that you say, but when we talk about data, obviously there's research. I think we need to make sure we involve women, because there's a lot of women, a lot of research that excludes women. So we try and make women more involved in that. And obviously the more we do that, the more data we have on women, that will inform, whatever it is that we need to do. That was one point I was going to make. And the other one was, in terms of overcoming barriers, I think we need to take the approach that not one size fits all, because we're very good at always clubbing things and putting things in boxes and whatever else. I think we need to think, particularly with the ICSs and a bottom-up approach, we need to think slightly more inclusively or slightly more broadly, and not assume that, because I'm looking at one woman, it'll be the same for another woman. And yeah, those were the points I was going to make.
Thanks, Rebecca. Fazana, did you want to come in next?
Yeah, so I really interested in what Rebecca just said, and how we still have a lot of work to do there, because we repeatedly say we don't want a one size fits all, because human beings are individual, yet we offer a one size fits all service. So it's great to have targets. Of course, we want to have targets to be able to justify taxpayers' money, because we are NHS. We're here to serve the NHS. But sometimes the things that we choose to measure can become disincentives. So if we take the example of cervical cytology, it's great to have a target that actually 80% of all our women in the country should have, or anybody who has a cervix should have a screening test. That is great. But the bit we're missing is the process that goes behind that. And I know that Dr. Nikki Kanani has just recently at Confed Expo spoken about the fact that funding streams might change, so areas of health inequality may get more funding than which I think is welcome. But it's how do we get that process right? So it's not just about then becoming punitive, because a GP practice primary care might have a million other things to do, so they're just focused on that 80%, and we inadvertently might be dehumanizing our women. So a woman who has had a very negative experience, maybe a domestic violence victim, something, might just have a really difficult time getting undressed. A 10-minute appointment is not going to do it for her. She might feel that her trauma comes back. Really practical examples. A lot of women have children. We have children. And, to bring the 2-year-old and the 3-year-old in with you to have a test for something that might develop in the next few years when you're a single parent and you can't actually feed your children at the moment, might not be the highest priority. So it's about how do we help the policymakers think about process outcomes as well as just the targets, but how do we, as Rebecca said, treat everybody with the dignity and the individuality that they require. And again, I am optimistic. I think we learned a lot of this in COVID vaccines. We did go out to sports at leisure centres, we did go out to mosques. Still, I feel a lot of work to do on a personal level. I still feel that women fell behind. That's a personal view. Not all women go to places of worship, but we made a start. We're on a start of a journey where we can take our healthcare to where the people are. I think now we just need to listen more to our individuals, because for some people just coming for that test is really, really difficult. And wouldn't it be great if we actually didn't need to do the test and actually we had the vaccinations and the self-test? Because what did Priya say? We can eliminate this cancer, and that's what I'm going to take away from this. This is something that we can eliminate from the UK, and that's amazing.
Thanks, Fazana. Priya, did you want to come in?
Yeah, I just think this point is really important. This whole, you incentivize towards 80%, and I think women, and especially BAME women, you get lost in the averages, and actually the hardest to reach. That phrase, there's a reason it's called hardest to reach. So when you think about the Global Alliance for Vaccines, they talk about 0 dose children, right? We're going to reach every child. It's not good enough to reach 80%. And you need to incentivize GPs the opposite way. I agree with you, Fazana. You should be incentivized for the people that are reaching the hardest to reach should be funded and supported. And as Rebecca said, to really understand why they're not getting reached? You know, why it's always the last 5, 10, 20% that require more effort. How do you support and incentivize reaching those? Like, that should be the celebration. Reaching 80% is not the celebration. That's your low-hanging fruit, right? It's the people that are working on the other 20% that should be heralded and celebrated. So I celebrate the people on this call because they're the ones that are working on the hardest to reach. So I hope that really comes across in the women's health strategy and the policies that are coming, because those are the ones that need resourcing and individuation. So I just thank you, Fazana, for saying that.
Thanks, Priya. And Rayhan, it'd be interesting to get your perspective from more of a secondary care perspective.
Well, sometimes I think in secondary care, it's almost too focused. What do people do in antenatal clinics? Well, actually, they spend an hour waiting to see the doctor because they're me and I'm very slow. What if you co-designed with women, as we're now doing, a health literacy project that women could learn about how their own bodies work in and out of pregnancy? So you might be able to take something forward. We're discussing here women suffering from socio-economic deprivation, and educational deprivation goes with that. And we have had evidence for decades that better education leads to better health. There's all sorts of opportunities if we just slightly think outside the box of what our own narrow confines of our professional roles are. And I think, you know, I promise you, someone as thick as me can do that. Anyone can do that. And I'm only doing that because it's co-design. Because when you actually co-design rather than talk about it, you discover things. We started setting up a women's health hub project in Tower Hamlets. We were unsatisfied with the boundary between primary and secondary care. We felt we needed a staging post. We think it could take over things like advice and guidance and clinic triage and allow women to get care quicker. But because we tried to co-design it, we realized that we had failed to have any provision for years for menopause care. Women are sitting miserable at home with terrible symptoms, and they needed to tell us, but we refused to listen. And it's all starting to open up because we're starting to listen. And that listening matters. There is bias in women's healthcare. It does intersect with socioeconomic deprivation and race. A clear example being around pain perception and women not being listened to when they're in pain in labour, depending on their background. Work is there to be done. But if you start opening out the conversations to be two-way, as many of my colleagues have done, I think it can help. One final point. It comes back to the pandemic. Although it doesn't feel like it in my workplace because everyone's off sick with the COVID again, I think we're in COVID recovery at the moment. And we have to keep our eyes open about that. All over England, they've set up high-volume, low-complexity surgical hubs in order to catch up with surgical treatment. How dreadful would it be if this catch-up was biased against women who are deprived? And there has been a risk of that because sometimes when you're trying to recover, you do it at pace. So we in the London region, in all specialties actually, rapidly tried to introduce equality impact health assessment so that we could really start to consider, well, if you set up a surgical hub, someone's got to travel there. How are they even going to get there? Who's going to look after their kids? What if they get there, there's no interpreter? And what does a DNA actually mean? Do we just write off things like did not attend? Or do we actually start to think about what it means about someone's life? So there's all sorts of ways in which I feel my eyes have been opened. And I know all the other people on the call and a lot of the audience are starting to have their eyes open too.
Thanks, Rayhan. Some really important themes from all of your panel discussion there about listening to women, co-design solutions with women and working with women, listening to them. And those things come up in our Q&As questions from our audience. So I'd like now to move on to some of those. So our most popular question from our audience is about how can we move away from trying to solve women's health and instead ensure women's voices are heard about what matters to them and what will work to address their needs. So I think we've covered some of this already, but anyone want to come in on that theme? Fazana?
I think mine's a really simple one, but it's actually quite hard to implement. It's listening with respect. So this is a true story. I'm a bit ancient now, so my children are 18 and 19, but I had both of them in my local hospital, in Newham Hospital, where I was a junior doctor. I was 30 and I was a GP. And I went for my antenatal appointment for my second pregnancy with a baby in my arms. Sadly, they're 11 and a half months apart. Don't even ask me about my contraceptive advice that I give to patients, but mine are 11 and a half months apart. And I was waiting, like Rehan said, for an hour, and the midwife very loudly said to herself, Fazana Hussain, I hope this one can speak English. And I overheard her saying it, and then she called me, and I was a practicing GP, and I felt powerless to say anything. I didn't say anything to her. And you can imagine that the consultation didn't go very well for me. And that's somebody who's in the health profession, who can read and write English. So I think my one message would be to really listen with respect and not just write strategies to say, oh, we want to co-design, but really listen to our women with respect.
Thanks, Fazana. And did anyone else want to come in on that question? We've had some similar questions about sort of the culture of women's health and listening to women's health. So, for example, one of our top questions is about what the attitude is at the moment about women putting up with pain and intrusive procedures as being part of a woman, as being part of a woman. What are the thoughts from the panel on how this affects women and it just being a normal part, or seen to be a normal part of being a woman? Rehan.
So I don't get this. If I'm referred for an endoscopy, all sorts of things happen on the day in order to make this procedure either less comfortable for me or a procedure that essentially I'll forget because I'm semi-conscious through sedative. If I go for an outpatient hysteroscopy, it isn't necessarily like that at all. If I'm having a minor operation, okay, I might have a lot of care and attention paid towards the pain relief during the operation, which I won't even have to ask for. If I've just given birth and I'm having a perineal repair, it doesn't always feel like that. At least now we're starting to talk about this. When Priya and I were clinical colleagues, no one even talked about this stuff. I would say it's actually, to my embarrassment, only in the last very few years that people have genuinely started to talk about pain in a different way. I entirely have to thank the women I look after for this. It is only through their voices finally being heard that we're getting there. What did I learn from that? You do not listen to women's voices, you will get it wrong. And we got it wrong for a long time, and we are starting to get it right. I'd be interested in the other panelists' views on this. I'd recognize mine are quite passionate on this topic.
I'm happy to add in that. I think there is absolutely, I would echo everything that Rehan said about really, listening, understanding, and seeing things with a parity that we haven't traditionally, which is really important. I think there's some other things which my eyes have been open to in the last few years, and that is really taking the time to understand different cultural norms, because we can have conversations and we can use the translators and almost think that we can approach things in an identical way. And what I've realised, certainly from working at the practice that I work at, is when we've done groups with different women who have an interest, whether that be the area that they come from, the language they speak, they're sharing a particular experience, a time of life together, and we bring them together and bring other people who are from that culture, and they teach us so much. So there's certain languages where there isn't a word for a pain or an experience or a way of feeling. So actually our very traditional medical models don't fit around them. And until we know this, until we highlight it and then find different ways to work with them, which come from those people in those communities educating us about how we can help with the tools to serve them, to help them, then we go back on time and time again. We run at things from a very medical model, which is quite traditional and which doesn't suit people, but more importantly, often doesn't suit women and doesn't suit the women that our services were not designed for. So I think there is something very, very simple about just stopping and listening and making time for those conversations where we understand people and then we work from that point.
Yes, so important, Louise. I'd like to move on to a slightly different question now from our audience. We've got a question in about the women's health strategy. So it'd be interesting to hear thoughts from the panel on what they think the women's health strategy will do to improve women's lives. What changes in services and interventions will look like, and it would be also interesting to hear from the panel what you think we could achieve from the women's health strategy. So I know, Priya, you mentioned about eliminating cervical cancer. With these types of policies and new things coming in, are those types of things possible now?
Let me take a stab and then others. Look, a strategy is a document, can be just a document that gets shelved, or it can be a tool to really sort of mobilize for change, right? So when someone says, is the women's health strategy going to transform things? Well, only if all of us hold hands and ensure it transforms. So one thing I would question, and I haven't been close to the whole process, you're hearing it from everyone here, and there's this thing, in global health, like no policy for us without us. So I would question how much co-designing of the strategy there has really been, and have all the voices been heard. And it's okay if they weren't completely in the process, but before it starts, turning into a roadmap and action plan, I really hope that there will be opportunities to make sure that the very people that it's supposed to be designed to benefit have a voice in how it then becomes transformative. So I think that's key. The second thing, and I'll keep going back to this again, simple mind, is I really hope we have a few things that we say have to be done, like all of us prioritize and will be done. And one of these things I'm hearing from everyone is like, everything will be co-designed, right? The other thing is think national, act local. My personal thing is let's go for something that we can prevent and eliminate, right? Are there a few things that we can get out there and say, we're going to do it well, we're going to be doing it with women, but we're going to measure and we're going to say we achieved, right? Again, to give people more hope and more momentum. But my caution would be something on the strategy is nothing without all of us making sure it is then, we hold the system accountable and we ensure the system includes the voices of the women to drive forward impact.
Thanks, Priya. Louise?
Yeah, absolutely. So I part of my role is strategy, and I couldn't agree with Priya more. Strategy as a piece of paper is, it's not helpful. It doesn't make change. Strategy is about what we live and what we do. And so for me, it has to be ambitious, and it has to provide the tools and the levers that allow us, and I say us as the collective of everyone on this call and far wider, to be able to make the changes. So it really has to give us the roadmap. It has to give us a collective, a shared purpose of where we're going, and perhaps some real things to get behind. And that's the what. But for me, it has to leave the how, because the how is the bit that we do with our communities, and we do in that targeted way, and that is what will really make the difference. The strategy will give us some of that top down, the bits we are really galvanizing around, and some of perhaps the intelligence, the levers, the research, ideas that have worked in other places, but the actual drive to make the change has to come bottom up, and these two things need to meet together. And if our strategy gives us that and gives us the levers to be able to allow that change, that momentum that we can all take from the bottom up, then that's where we will get real change.
Thanks, Louise. And I'll come to one final question from our audience. So this question is, where in a woman's life cycle is the largest gap in health services, provisions, awareness or education? Is there a particular gap that stands out to any of you? Or is that a trick question? Is it gap everywhere? Louise?
I'm going to go in here, really short answer, everywhere. I think it is the whole way through the life cycle. And if I could pick one area to focus on, preconception, because that does it for the whole life cycle. If we start at that bit, we really make big changes for the whole life course and for the next generation and the next generation. But I don't think you could pick out, in my opinion, one area. I think we have to look at it across the whole life course.
Thanks, Louise. Rebecca?
Yeah, I would agree with Louise. I think it's the whole life course. But just to add on, rather than just focus on preconception, I think it's from whatever age, as early as we can, talking about sexual health that leads you into all of these other areas. I think when you look at it from the point of let's look after ourselves and our health and our sexual health in general, that gives you the platform to then inform all the other areas, which hopefully fill in the gaps. Yeah.
Priya, yeah.
I just want to, I want to build on what Rebecca said, and there was a question that came into the chat. Start as young as possible. Look, I grew up in a family, there's no way we were talking about sex, because of course I wasn't going to have sex till I got married, right? And my life changed because we had sex education at school at the age of 8, and the boys and the girls had sex education, right? And education around health. We can't keep putting everything on the girls and the women, right? Like, we have joint responsibility, and men also need to be educated as boys, and we can't just be educated on the stuff that is relevant to men in our society, right? And so I really think it's important to start at the youngest age possible. And I've seen schools aren't investing in this anymore, or that, you know, the biology teachers teaching sex education, which is always a bad place to be. So I would build on what Rebecca said and start with health and sex education as early as possible for boys and girls, because then, as Rehan said, education leads to better health outcomes.
Thanks, Priya. Really, unfortunately, we're running out of time. We could, I imagine, talk about this all day. But I'd like to get some final reflections from each of our panelists. And I've got one specific question I'd like to get your reflections on. What's the one thing you'd like to see in the women's health strategy? So I'll just go around. Priya, do you want to start?
Oof, the one thing I'd like to see. God, there's been so many ideas on this panel. I'm probably going to go for bold ambition. I really want to see UK eliminate. I've lost so many women to cervical cancer. Just get the boys and girls vaccinated and then pull through, as Fazana said, with screening and treatment. So I'd love us to be the first country that eliminates. Sweden's put a stake in the ground. I'd like us to beat Sweden, right? We can do this within the next 7 years if we all focus. So let's do that. So I think I'll close with where I started. I'd really like to see that, but there's been some amazing ideas here, and I hope that it gets implemented with these people leading, because the people on this call will make sure that happens in a co-designed way, so there are no more of these hard to reach people. We actually get to everyone everywhere.
Thanks, Priya. Fazana?
So I'm going to be naughty and change the question. I would like to see the women's health strategy implemented so it makes a difference for my 5,000 on the ground that I personally look after, for the 320,000 documented people in EU and probably more, and for the people in this country who at the moment are suffering with financial issues, care responsibilities, long COVID. So I want to see, even if it's one thing, whatever it is, not a set of 50 priorities, but one thing that's implemented that makes a difference for my patients, that makes a difference for my daughter. And I'd like us to acknowledge that Currently, we do not live in an equal world, and we need to say so, because it's only if we acknowledge that, then we can move forward.
Thank you, Anna. Louise, did you want to go next?
So for me, it would be real, tangible metrics that matter to real people, real women. And I'd want those to be both short-term and long-term. And I'd want us to do it with the same level of commitment that we do to some of the more constitutional targets that we're held to. So a real commitment to deliver on them and to hold ourselves to account as a nation for delivering on them.
Thanks, Louise. And Rebecca?
Thank you. I am going to say inclusivity. So whether it's being included in research or whether it's being included just in literally anything, I think that needs to be embedded within the health strategy. In the HIV sector, there's a term that we use, it's about being meaningfully involved. So whether it's within the decision making, whether it's in the research, but make sure people are meaningfully involved, and that way, just inclusivity for me.
Thanks, Rebecca. And Rayhan?
Well, it's 1 o'clock, so I'll keep it short. So I guess my goal is that wherever we get, it's so embedded in the DNA of how health systems work that webinars like this become less necessary in the future, because it's so much how everybody thinks.
Thanks, Rayhan. Great thing to end on. So that's all we have time for today. Thank you to our speakers and for those of you watching. We encourage you to share the link for this event with colleagues who can register and watch on demand. We also really value your feedback to help us continuously improve our events. So please use the feedback option on the menu which you can navigate to on the left-hand side, and we'll send out a link to the survey shortly. And finally, thank you again to our event sponsors, MSD. Thank you.